Chelsea Myers, can you hear me?
Now I can. Thank you.
Okay. So,
I did not hear anything you said until just that moment though. So
well, the question is, do you have a schedule you need to meet? Is there a timing issue for you?
um I have super quick testimony and would love to be able to get to another meeting. So if you don't mind me going first, that would be great.
Terrific. Now that's fine. And I'm asking others in the room. Is anyone else up on Zoom with us? Yes. Well, Lisa and Shilpa are both on Zoom. Okay, Lisa and Shilpa, do you, either of you have a time sensitive schedule?
No, it's fine.
Okay, and Shilpa, you're muted.
Oh, that should be fine with me.
Okay,
Can
good.
you hear me? Yep.
Yeah, that's terrific. Thank you. Okay, so we'll start with Chelsea and then we'll move through the list. Thank you.
All right. Good morning. My name is Chelsea Myers, and I am the Executive Director of the Vermont Superintendents Association. First and foremost, superintendents support safe and healthy schools. They show up each day committed to creating environments where students can learn and thrive. But I would be remiss if I did not reiterate a point you hear from us often. Each year, committees all over this building discuss new proposals to add to schools, and in the same breath, discuss how expensive schools have become. I took the time to read the testimony provided on this bill by other individuals and entities. I have no doubt about their passion, credentials, or research. However, several said that this would create no additional burden for schools. And even the Agency of Education reported to the media that it thinks that this would not be a problem. I respectfully suggest that we hear directly from those who would need to implement this. Assumptions about impact are not the same as understanding the day-to-day operational realities in our schools. Each year, the General Assembly passes very well-intentioned legislation, and each year additional requirements are placed on schools, often with hidden time commitments and costs, paperwork, training, communication, procurement adjustments, and compliance oversight. To be frank, I do not know if this is one of those cases, but I believe we should find out before moving forward. I attempted to line up a few food service directors to join me today, but as you can imagine, they are very busy nourishing Vermont students. I would be happy to continue working to organize that testimony, but would just need a little bit more time. Until those directly responsible for implementation have had an opportunity to weigh in, I respectfully request that you pause taking action on this bill. Thank you for your consideration.
Okay, so thank you for that. And actually, when we were looking for someone to testify, we were thinking of food service folks, but didn't have the luxury of names. So if you can send names of food service folks who might be helpful with this to Callista, and then we can organize the testimony. That would be very helpful. I know they have certain constraints about their funding and the USDA and everything else. And just the language in the bill is introduced is consistent with what is being recommended at the federal level right now. So maybe we won't see a disconnect there, but you never know.
Yeah,
Yeah.
I frankly don't know. I'm in touch with a couple of food service directors, but I haven't been able to like make that. It's just been through email so far. So if I can just get a little more time, I can help Callista organize that and get some folks in for you.
All right. So I mean, send her the names, and
I
she's
sure will.
yeah, that
Yep.
would be great. And I know in the past, the Burlington folks have been extremely helpful when we
Yep, that's who I'm in touch with. Yep.
Oh, that would be good. Okay, well, and others that you think would provide information would be great.
Absolutely.
Well, thank you. Thanks for your time. Appreciate it.
Yep. Thank you.
All right. So we'll move on to Shilpa Revelia, a gastroenterologist. So it's Dr. Revelia. You here?
Yes, I'm here.
Oh, good morning.
Good morning.
So you're sitting with the Senate Health and Welfare Committee. We've got one member who is away for personal reasons and another one who will be coming in from a meeting. So the others are Senator Benson, Senator Gulick, and Senator Lyons, myself.
Nice to meet you all virtually.
Yeah.
So, Chair and members of the committee, thank you for the opportunity to testify here today. My name is Dr. Shilpa Ravella. I'm a practicing gastroenterologist and author with expertise in nutrition. Previously, for the better part of a decade, I served as a full-time faculty member at Columbia University Irving Medical Center in New York City. I'm here to speak from a clinical and a public health perspective on S26. Thank you for considering this bill, which focuses on foods and beverages served in school settings and restricts certain synthetic food dyes. From a medical standpoint, there are 3 points I'd like to highlight. First, the scientific evidence. The body of data on artificial food dyes and children's behavior has been growing consistently over the years, and the results are cause for concern. This data includes diverse studies in both humans and animals, including randomized controlled trials, which are long considered the gold standard in scientific research, and observational studies. The data points to associations between synthetic food dye exposure and changes in children's behavior, such as inattention, hyperactivity, and restlessness. We also have some literature highlighting plausible mechanisms through which food dyes can cause harm, like neuroinflammation or inflammation of the brain, as well as neurotransmitter disruption and oxidative stress. So overall here, we have an important story emerging regarding how these dyes may affect both animals and humans, as well as plausible mechanisms behind their effects. Second, the clinical context and nutrition perspective. In my gastroenterology practice, I frequently receive questions from patients and families about diet, additives, and overall health. While I don't treat children clinically for attention or behavioral issues, my work in GI nutrition and my research on inflammation gives me insight into how dietary exposures can affect overall health. How children eat is immensely important for their overall health. Diet is one of the few modifiable factors that parents can control, and schools are where children consume a large portion of their daily food. Importantly, these synthetic dyes provide no nutritional benefit and are not essential to food safety or quality. In fact, foods containing synthetic dyes also tend to contain additional additives that are harmful to children's health. For example, foods and drinks sold by the top 25 US manufacturers in 2020 with synthetic dyes contained on average 141% more sugar than products without synthetic dyes. And we know that there is a wealth of literature on the health harms of excess sugar for children. Third, the policy question. FDA safety determinations largely focus on acute toxicity and cancer risk. Behavioral and neurodevelopmental effects are more difficult to study historically and have not driven regulatory thresholds. States often step in when emerging evidence raises concerns in children's environments. FDA safe when it comes to taking additives off the market often actually means absence of proof of harm, not proof of safety. In contrast to the US, the European Union's public health protection policy follows the precautionary principle under which credible evidence of danger to human health merits protective action despite scientific uncertainty. Many major food companies in the US use artificial food dyes in America while selling the same food in Europe without dyes or with natural color. It's possible for American manufacturers to produce dye-free alternatives of their foods. Some already do, and several states and districts have transitioned to dye-free foods in schools without major disruption. In line with testimony previously that you have heard regarding expanding this bill, I urge you also to consider the mounting data on potential health harms of additional additives, including preservatives, BHA, potassium bromate, and propylparaben, which are currently covered under 3 statewide bans, and titanium dioxide, which is in several state bills. Titanium dioxide, a color enhancer and anti-caking agent, was banned in the EU in 2022 after a safety assessment concluded that it can damage DNA and harm the immune system. Other additives to consider with potential links to cancer include BHT, TBHQ, propyl gallate, and aspartame. Many of these additives serve superficial functions in food and can easily be omitted or replaced with safer alternatives. In medicine, we often act under uncertainty when certain conditions are met. Potential harm, broad exposure, and minimal countervailing benefit. S26 fits that framework. The bill does not ban these dyes statewide, nor does it restrict parental choice outside of schools. It simply sets a standard for foods provided in a publicly regulated setting to children. From a physician's perspective, this is a reasonable precautionary step that aligns school food policy with child health priorities while evidence continues to evolve. The benefit of these dyes is essentially cosmetic. S26 protects one of our most vulnerable populations in an environment in which they are attempting to learn, grow, and thrive. I urge you to vote accordingly. Thank you for your time. Happy to answer questions.
Thank you very much, Dr. Ravella, and you've included some references for us in each of the areas. Have you testified in other states or do you know about other places that have acted on this policy?
There are other states that have acted on this policy. I actually was a part of the initiative in California with Lisa Lefferts to ban food dyes.
Good. And remind me, how long has the EU had this ban? Do you know?
So they have had warning labels on many of their food dyes. So they have warning labels with items that contain food dyes, but most manufacturers actually don't even put those dyes into the foods that they produce in Europe because they know they can't get away with it because of those warning labels. So here in the US, American companies use dyes that they would not use in Europe. So even if some of those dyes don't have an outright ban in Europe, they're not typically used.
Wow. But they do have warning labels.
Say that again, please.
Yeah. So and your do you know if these foods are allowed in their schools, or is it with the warning labels only and then manufacturers not putting them in? Sounds like they're doing the right thing regardless.
Correct. Some of the dyes are banned, some have warning labels in Europe, and the global effect is the removal of these dyes from the food system and from school food systems because American manufacturers cannot sell the same foods in Europe using the same dyes that they use in America.
We hear this all the time. So EU reaches ahead of us.
Yeah.
All right, questions committee. Okay, thank you very much for being available. And if we have questions, we may reach out again.
Sure, absolutely. Thank you for your time.
Yeah, terrific. And so we have Rosie Kruger here. Here you are, Child Nutrition Program. And you've heard the comments from the superintendent's group, and that we're going to try to get some folks in, and maybe you can help us with it. Sure.
So for the record, Rosie Kruger, I'm the State Director of Child Nutrition Programs for the Agency of Education. I did submit written testimony, but I submitted it a little late, so I brought copies for you as well.
Oh. We have it.
Oh, great.
That's good. Awesome.
So at the Agency of Education, my team is responsible for implementing the federal child nutrition programs, including the school meals programs. And so we are out in the schools all the time, looking at what is actually being served, looking at menus, recipes, ingredient labels for both the school meals and also for the other foods that you've mentioned in your bill. They're called at the federal level smart snacks, but they're the foods that are sold to kids outside of the meal program during the school day, which is defined as midnight the night before to 30 minutes after the school day. So we're all over the state looking at these statewide all of the time. And I have good news for you, which is that we're really not seeing a lot of these products in Vermont schools.
Good.
So we had given a comment last year that we think it would be terribly difficult for Vermont schools to comply with the food dye restrictions because we're really not seeing those food dyes in Vermont school meals programs. The one place that we're seeing those is in a handful of breakfast cereals. Those breakfast cereals, I believe, are sort of either being reformulated or on the way out because they also, there's some recent federal restrictions that went into place around the amount of grams of added sugar that are allowed in breakfast cereals, school meals programs. So we are seeing these national manufacturers actively reformulate their products in response to some of the same restrictions in other states. So even as we've been looking at this, we've been seeing fewer and fewer of these items included in the ingredient labels as they're being reformulated. The other place that we see food dyes is in those smart snacks that are sold outside of the school meals programs. Again, not extensively, as you heard in previous testimony, a lot of food manufacturers have a specific school meals formulation for their product that is branded exactly the same as the grocery store formulation, but is reformulated to be whole grain rich and meet the sodium and fat restrictions in the school meals program. And so we've already seen the manufacturers take steps to change those special school meals, school food formulations. But we do still see a few food dyes in a couple of those products. Again, those aren't part of the school meals programs. There are plenty of other products on the market that would comply. So we don't see that food dyes particularly as a significant consideration. The draft 1.1 of the bill includes some additional additives. And so we did recently take a look at food labels to see if any of those are included in Vermont schools. And we're really only finding 2 of those. So most of them are just not in Vermont school meals right now. But 2 of them are, and they're mostly in things like packaged crackers, breakfast sausage, and pepperoni. And there are products on the market that don't have, similar products that don't have those additives. And again, we're seeing manufacturers actively reformulate these products. So by the date of implementation, we're anticipating that either those products would be reformulated or other products would be available. If you decide to go further than this, further than those ingredients that are listed, we would want to be part of that conversation because depending on what you do, I know there's conversations in general about concerns about ultra processed foods and packaged foods. And in general, in Vermont school meals, we have a lot of scratch cooking. The programs are really doing some amazing stuff with local foods. And if you haven't looked at a school meal recently, I'd really encourage you to go to your local school and check them out. They're really good. But where we do see some packaged foods is at breakfast. And that's one to deal with labor issues, but also to deal with offering breakfast in the classroom, grab and go breakfast between class periods. And that's a situation where a convenient, portable, prepackaged food works well for that situation. And so if you were to take further steps that might impact those products that are being offered, we want to have that conversation with you about weighing the pros and cons of potentially schools having difficulties continuing to offer those options, those breakfast in the classroom, that kind of thing, versus restricting those. But with the ingredients specifically in this bill that you're looking at, we don't think that would stretch it back.
Oh, good. Thank you. This is really helpful. And because as we heard from the superintendents, they were concerned about the ability to implement, in the kitchen. And
yeah, and we would absolutely share those concerns in general.
Right.
But looking at these specific ingredients, we think that it will.
so those ingredients, it's not a big deal. Also, the date of implementation is
It's a year out.
27, so there's time to sort it out a little bit.
The other place that we've noticed is the bill does not currently have any compliance or enforcement, penalties for non-compliance. So if you wanted to do that, that's an area where we have some suggestions. And we have some suggestions about how to do that in a way that would be require as little additional work as possible for both the schools and AOE. Because again, as the Superintendent's Association shared, if you did this poorly, you could add a lot of administrative burden to schools and to the AOE, and we would discourage you from doing that. But because we're
sorry to interrupt. I just wanted to quickly chime in on the packaged food piece.
Okay, well, let's finish the compliance and then we'll do that.
Okay. I mean, it's already gone by, but
No, we'll come back to it. Don't forget your question.
well, I have a couple.
Okay, yeah.
Okay.
Finish the because you've got 3/4 suggestions.
Yeah.
We can look at those.
So because we're out in the schools on these federally required reviews, we're in every SUSD at least every 3 to 5 years, but more often for technical assistance visits as well. So during those federally required reviews, we are having the schools submit menus and recipes and labels to us, and we're reviewing all of those to make sure that they comply with the federal nutrition standards. So if you limited the compliance review and aligned it to that administrative review that's already occurring, the schools would not need to submit additional documentation to us. We could look at that existing documentation. Again, that includes both the school meals and those competitive foods sold outside of the school meals program, or both of those. And so we could review that documentation for this list of ingredients, and it would be no additional work for the school food authorities, and it would be a very minimal amount of work for the AOE, assuming you left it to that list of products, of ingredients that's in the bill currently. Okay. So that is our suggestion. If you do want to add a compliance mechanism, that would be the simplest and would not add additional administrative burden.
Senator Tulowitzki.
You're welcome. Packaged foods, I just would like to speak to that. Because this is my concern. Burlington had a award-winning food service program, and then this Burlington High School was shut down. They had to visit Macy's. Guess what? Department stores don't have kitchens. They don't have like industrial school kitchens.
Oh, right.
So we had to go from this really great food service program to prepackaged breakfast bars or whatnot. That's just a reality. I mean, the quality of the food definitely suffered, but I worry that as we, with the PCB mandates and the schools possibly having to close because we no longer fund school construction aid, and there are a variety of issues in our schools, what we experienced at Burlington could play out across the state over the next, I don't know how many years. And I am worried that we will have to rely on packaged food that may not comply with what's in this bill. As much as I would like to ban red dye, along with a lot of other chemicals like paraquat and PFAS, it's just the reality of it is more complicated.
So what is your thinking on that one?
So specifically the items that are in this bill, there are plenty of packaged foods that don't meet those items. If you went beyond that and started to get really in depth into other sorts of restrictions, then definitely we might have a conversation.
So, and if there were a compliance piece where they're reporting to you and listing those things that might be non-compliant and have a reason, I don't want to poison kids, but nevertheless, if Burlington had to go with that package.
Again, I really don't think that there's a need, like there's plenty of other packaged items that don't suit these ingredients.
So that's good.
That is good.
Yeah.
My only other piece is if you would be willing to speak to what we can call them unfunded mandate, but things that we ask the school to do, we keep piling on, and yet they don't come with appropriations. In fact, we're in the midst of potentially destabilizing a lot of the schools in our state. So I'm wondering how you feel about because you did just mention this could mean more staffing and more administrative burden. That is a financial that has money attached to it.
Absolutely.
So I was just wondering if you could speak to that as well. So that's another concern.
Yeah.
Again, as much as I want to.
No, it's always a balance for policymakers. And if you were to go beyond this and have lots of restrictions on packaged foods, or if in your compliance you were to require that they actively submit stuff to us, or go beyond that, you certainly could get into the world of unfunded mandate. Based on our review of the foods that are currently being served in Vermont schools compared to these ingredients, there's only a few of these ingredients that we're actually seeing. And again, those manufacturers are actively phasing those out. So, and there are alternatives.
Do you think it's helpful for us to hear from some food service?
Absolutely. They're always, I can speak very well to the statewide situation, but an individual food service director can tell you a lot more about what goes into their individual purchasing decisions. And so the School Nutrition Association is sort of that statewide organization to speak to you about that. And they have lots of great food service directors who thought a lot about this and are doing some really great work.
So what, can you send the contact information to us and look at that? That'd be good, thank you.
And then beyond compliance, you know, you could ask the agency to do a compliance check. Do you want to do a penalty? Right now, there's no penalty for non-compliance in this bill. We gave you some suggestions that you could think about if you want to do that. Ranging from just, you know, the AOE would require corrective action. Corrective actions can be things like writing a plan for how you're going to phase the product out, or submitting documentation to us or attestation that you stopped offering the product. Those are the sorts of typical corrective actions that we would assign if they were serving a product that was not compliant with the federal requirements. You could, you know, do something like requiring that they notify households that they've served this product. There's not a lot of a basis for that, but you know, that might be a sort of a encouragement to follow the requirement. And then you could do a fiscal action. I think we certainly wouldn't recommend doing that for a first offense. When we're talking about
Fruit Loops last Wednesday.
Yeah. And so in the school meals programs, the federal requirements, we typically only issue a fiscal action if it is a repeat offense. And even then it's restricted to certain categories. You cannot, I do want to caution you, you cannot take back the federal funds for non-compliance with a state requirement. So if you wanted to do a fiscal action, it would need to be on the state funds, you know, the Universal Meal Supplement or one of those state funds that we provide. Again, maybe not a road you want to go down. We're just trying to present you with what your options are if you want to look at it.
No, that's helpful. It helps us to look at it holistically. Appreciate that. Not inclined right now to think we need to have a huge penalty. It sounds like things are already in good position across.
Yeah, and that's really why we don't have a lot of concerns, just because we're not seeing these products. I do want to clarify, earlier testimony said that the AOE supported the bill, in a testimony you heard from last week. And I want to be clear that we've not taken a position on the bill. We did give a comment to our reporter last year that we just thought it wouldn't be particularly difficult for schools to comply.
Understood. Go ahead.
Quick question. I think the idea of penalizing schools, especially in a financial way, is not productive. How would the AOE, instead of using a stick, how would you be able to support schools in implementing this so that they don't end up facing negative consequences down the line?
I'm glad you asked that. At the end of the testimony, my written testimony, there's a whole list of things that we're already doing to really encourage scratch cooking. So we do a lot here. We do a lot of free training. We have a whole seasonal cycle menu toolkit that was developed by a wonderful Vermont food service director that gives a whole menu and the associated recipes for scratch cooking, seasonally adjusted based on local foods available in Vermont different times of the year. So that's just sort of a plug and play resource that any food service program can use. We operate the local foods incentive already, which gives additional funds to schools that are purchasing a certain percentage of local foods. And we've just issued our report on that for this year. We're seeing really good success there with that program, including having a Vermont school district. When I say school, I'm thinking School Food Authority, which is the FUSD. That is serving 31% of their foods as local to Vermont. So really impressive stuff.
That's great. Do you do anything to help like a Macy's scenario?
So we have a school, both a state and a federal school equipment grant. And the state grant, federal one we don't have a lot of control over, and it's actually been cut in recent years. But the state one, we have recently made a bunch of updates to it to try. We're seeing folks not really taking advantage of it. So we removed the required matching requirement, and we increased the dollar value, the maximum dollar value, and we've simplified the questions, and we did see some success with that. This most recent round, it was fully, we were able to fully expend the funds. So we offer that equipment. We also just offer a lot of training and technical assistance. So when somebody's in that situation, we're available to go in and kind of help them figure out, okay, what can we do with what we've got? Who can we work with? Who, in a neighboring school district? How can we, bring in meals? What makes sense here?
I know if you did help Burlington in that.
I'm sure we had conversations with them. Burlington has very competent food service staff. And so I think, they really took it on. But I know that we did answer various questions about, sort of what was allowable in terms of when the kids were dispersed off site as well, how they could get the meals to them. It's a very challenging situation, and I know we did provide a lot of help to them.
So we're gonna, those are good questions to ask, and I think we've got a lot of information here that we can use as we go forward. Appreciate it. And, we know where to find you.
Certainly.
That's great. Thank you for your work. This is terrific. I suspect that if we move forward with the bill, which I'm thinking we might, I'm interested in doing that. Senate Education may want to check in with you. Sure. Thank you. So. Committee, unless I hear different from you, we'll continue to get testimony and we'll get the food service folks in on the bill. Thanks for your work. Okay, so we are moving on to S-197, which is the primary care payment reform bill. We'll let the room sort of air out.
So that means you can lean on me.
What?
Then we're gonna need a doctor.
Oh, wait, before we do this, Katie, we have, I'm sorry, Lisa Lefferts, I didn't realize that you were still there. My huge apologies. And we really would like to hear your testimony. My oversight.
No problem.
Let's go right ahead, please, on with your testimony.
Okay. Well, thank you so much. I'm Lisa Lefferts, a science consultant. Previously, I was senior scientist at the Center for Science in the Public Interest, and my focus was on chemicals added to food. Before that, I served on FDA's Food Advisory Committee when it considered the issue of synthetic food dyes in 2011. And I also was the primary author of the successful petition to FDA to ban Red 3, which is a cancer-causing synthetic food dye. Thank you so much for this opportunity and for considering this bill to prohibit synthetic dyes in school foods. So my bottom line message to you is that S-26 is grounded in science, it's very doable, and it's really needed. And I also would like you to encourage considering to expand it to consider additional chemicals of concern that I think are very doable, and I'll say more about that. Synthetic food dyes can cause or exacerbate neurobehavioral problems in children. That's actually a quote from the best assessment on synthetic dyes ever conducted. And you don't have to take my word that it's the best. 30 other scientists and over 20 health-based organizations said that too. And we said that it's the best because it was the most comprehensive and rigorous such assessment ever done. It was over 300 pages. It took over 2 years. And unlike some other assessments, it looked at, it used a state-of-the-art systematic approach to examine all of the evidence. It was open for public comment and it was peer-reviewed. Now, we can use the word cause, which is a word that scientists do not use lightly, in part because, as Dr. Ravella already mentioned, the evidence includes 27 clinical trials considered the gold standard for showing a cause-effect relationship. These trials were conducted on children and are designed to hold all the other variables constant, except for whether dyes were present or not. So we know that the effect is really from the dyes and not from something else. It's very rare, in my experience, to have this kind of human evidence on an additive in food. Not only do we have all that human evidence, we also have evidence from animals and test tube studies. More importantly, all those 3 lines of evidence, the human, the animals, the test tube studies, all converge to reach the same conclusion. And that strengthens our confidence that this really is a true effect. Now, by neurobehavioral effects, we mean that dyes can cause or worsen hyperactivity inattention, sleeplessness, and restlessness. Just what kids in school need, right? Those are serious side effects that can have long-term consequences. Synthetic food dyes can affect neurotransmitter systems in the brain and actually cause microscopic changes in brain function. They're completely unnecessary. Their purpose is only cosmetic. They can be omitted entirely, replaced with safer alternatives like grape skin extract, for example, or even better, real fruits and vegetables. Now, we know that they're unnecessary because many companies, both here and in Europe, have reformulated their products to eliminate them. The bill is very doable since few schools contain synthetic dyes and dye-free alternatives are readily available. You heard that already from the previous speaker, and I have heard that there have been a number of analyses and other states have found that to be the case. In fact, by the end of 2025, at least 9 states had enacted laws that restrict the use of dyes and other additives in meals served in schools. Many schools nationwide eliminated synthetic dyes and other additives of concern well before states required it. I had the privilege of working with schools back in 2014 to identify additives of concern, and many schools have been adopting that guide that was developed. 3 states, Arkansas, California, and West Virginia, have adopted statewide bans on certain additives. Now, you've already heard previous testimony asking you to consider expanding the bill to include additional additives, and I think that's a good idea. The 3 statewide bans cover BHA, potassium bromate, and propylparaben. BHA is a preservative, and it's listed in the official U.S. report on carcinogens, which is a congressionally mandated report as, and I quote, reasonably anticipated to be a human carcinogen. It's been listed since 1991. What is it doing in our food supply? Potassium bromate is added to flour to increase bread volume. Bromate is considered a probable human carcinogen by the US EPA, and it's banned virtually worldwide. Propylparaben is another preservative that has effects on sex hormones and causes endocrine disruption and reproductive issues in animal studies. The US is really an outlier in allowing these chemicals. None of those 3 are permitted in Europe. You don't need them in food. How many of you have BHA, propylparaben, or potassium bromate in your kitchen cabinets? In addition, I'd suggest you consider 3 other preservatives, which some evidence suggests that they may pose cancer concerns, and that's BHT, TBHQ, and propylgallate. These are also unnecessary. They can be replaced by safer chemicals like vitamin E, by packing foods under nitrogen instead of air, or just left out. Potato chips that don't have them taste just fine. 2 others, titanium dioxide, as you've already heard, is banned in Europe from food. And it's due to concerns that extremely tiny particles of it, called nanoparticles, could accumulate in the body and damage DNA. Titanium dioxide is in several state bills, and it's prohibited under Arizona's Healthy Schools Act. Aspartame is considered possibly carcinogenic to humans by an arm of the World Health Organization, and it's prohibited in certain school foods in Louisiana. It just doesn't make sense for children who are at school to learn to be fed unnecessary chemicals that make it difficult for them to learn or possibly increase their cancer risk. It seems to be up to states to protect their citizens from chemicals in the food supply, since it seems to be so difficult for FDA to act. I'm happy to answer any questions you might have and urge you to vote yes on S26. Thank you so much.
Thank you very much. This has been really good, comprehensive assessment of the chemicals that we have put into the bill. And the references are hugely helpful. Committee questions? We don't have any at this time, but they will pop up, I'm sure. And it would be great if you might be able to answer them for us either by email or coming back.
I'd be happy to. And I just want to mention that there's a free online tool that schools can use. I've put it in my sites that can help them identify which school foods contain these various additives, not just dyes, but some of the other ones I've mentioned, and identify alternatives to those foods. The analyses I've seen is that it's a very small percentage of school foods that contain these chemicals.
Do you have that, do you have that link in your references?
I do.
Okay, good. So we can find it there. All right, thank you. Might be something good to mention in the bill. Actually.
It's called Green Onion, the tool.
No, yeah.
yeah.
Onions are good. Okay. All right. Thank you very much, Dr. Leopard. We appreciate your time and your patience with us.
Thank you.
All right. So committee, we're going to move on. Now we're going to move to 197. And we have Zuri Song from the Harvard Medical School, who's also being patient with us, available for the next 40 or 50 minutes. Dr. Song, thank you for being here. And you are unmuted. That's great.
Thank you so much for having me. It's an honor to be here with you.
Well, thank you. And I believe that you have sent us, you have not yet sent us any information, but will you do that after we've heard your testimony?
Yes, and I have a few minutes ago sent over a PDF.
Okay, great. Well, so we just need to refresh. We'll get it on our web pages. So
I'm happy to share screen and
Go
share
ahead.
this with you now if that works on your end.
It will.
Okay, got it. I just sent over a request to share screen.
You're getting it.
Thank you.
All right. Oh, terrific.
Do the slides appear on your side?
We're all set to go. Perfect.
Thank you.
Go right ahead.
My plan here was to share with you the motivation, both from a national perspective and more locally at the state level, for this bill and also this general era of efforts to support primary care. And I'm going to break this very briefly into three parts: the federal, state, and private sector responses to what's happening in primary care today. That I'm happy to talk more about specifics in any aspect of this. We all know from various sources of data that there is a profound primary care shortage in this country. Many states face this to various degrees, and national bodies like the Association of American Medical Colleges have put estimates of these shortages out there in the literature. The exact number matters a little less than really the general degree of these shortages. We know that access to primary care is very much lacking in many communities across the country, and it's gotten worse in recent years. It turns out that, strikingly, less than 1/3 of residents who have applied to and matched into primary care residencies, those are primary care tracks of internal medicine residencies, actually stay in primary care by the end of their third year. Less than 1/3 will stay by the end of graduation. And this has also declined from a little bit closer to 40%, maybe a decade or a decade and a half ago, to now less than 1/3. And this data on the right shows us that many of the primary care residents are heading into hospital medicine careers or other subspecialty careers. This further adds to the shortage of primary care, especially at a time when the population is aging, prompting many states and our nation as a whole to try to do something about primary care access. Let me first review quickly the federal response. Medicare, as a program has tried to support primary care in many ways across the years. Largely, this has been through adding new billing codes for new types of office visits or counseling or coordination of care that primary care clinics or practices can receive Medicare dollars for. These billing codes have been studied. There's a new wave of them just last year and this year. Last year, there was a set of 3 advanced primary care management codes, which I've listed here on the left. The details are less important for our current discussion, but advanced primary care is essentially defined in this table to the left. And that allows practices to receive, in the study down at the bottom left here, anywhere from, let's say, for a middle intensity or a middle level of advanced primary care visit code, anywhere from $36 to $49 per patient per month. For a more complicated or medically complex patient case, the practice could receive anywhere from $80 to $107 per patient per month. So that's potentially substantial support. And this year, in January of 2026, there was a second set of new codes for behavioral health integration that offers the dollars seen here, again on the bottom left, per patient per month, depending on the type of behavioral health integration the practices do. And this is the latest representation of these federal efforts to help primary care through the fee schedule. The challenge, however, has been that for the vast majority of these codes that have been added across the last 15, 20 years, meant to help primary care, they are rarely billed. They're rarely actually used by practices to garner additional revenue. In the vast majority of cases, less than 10% of eligible patient visits that could have garnered one of these codes for extra dollars was actually billed by the practice. There are many compelling reasons why this is the case. These include that practices may not have the capacity to actually do this extra work. They may not have the bandwidth or staffing to do this work. But importantly, these new codes have also never been designated as a preventive service, and therefore they are not free from patient cost sharing. Thus, by billing these codes, practices are actually hitting patients with a second copay, and it's understandable how many primary care providers would be quite reluctant to do that. Understandably so, for the well-being of their patients. And so this federal response has been well-intentioned. It's been persistent through the years. It has not resolved the primary care crisis in front of us. And this is one of the reasons that these codes have not really reached the front lines or generated the type of revenue that we think might be able to stop the bleeding in primary care, if you will. Another reality that's been underappreciated is that every attempt to add a billing code for office visits, which is the bread and butter of primary care, has also been received in large part by specialties. In this study currently under review with many colleagues, down at the bottom right, you basically see the take-home point that only 28% of federal subsidies or dollars put into primary care billing codes actually reach primary care. That's about a fourth. The other 3/4 of these dollars going into office visits are actually received by specialists. And that's because specialists do office visits too. And in aggregate, specialists do more of these office visits and receive a higher share of these total dollars. So if we take a quick step back and look at 2017 versus closer to today, 2023 on the top right, it turns out that despite all of this need for primary care and all of this urgency to help the aging population as patients become more medically complex as they age and get a little bit sicker and primary care gets more complicated with new drugs and new services and new specialties to coordinate, it turns out that despite all of that, we as a country have been spending less, not more, on primary care. Just over time, it's the level and the shares are going down. That's what the top right shows. So that gets us to the state response, which is more germane to our conversation today. And in a short review article on the top right here, which I've just cut the title of, I can report that, as many of you know, many states across the country have taken steps to concretely do something about this primary care crisis. My colleagues and I studied Rhode Island as an initial leader in this trend. Rhode Island, as many of you know, used its affordability standards as a way to increase the share of healthcare spending allocated to primary care, initially by 1 percentage point per year till it reached a certain threshold. And this policy has evolved over the years and has also been paired with other efforts to improve the value of healthcare spending, which we cover in this article. But it's meant to be a representation of what many states are trying to do. Here in Massachusetts, where I am, we currently have 3 bills going through the state legislature that also aim to support primary care in the same spirit, rowing in the same direction as our colleagues in Rhode Island, Oregon, California, and here in Vermont.
Can I interrupt you
Yes,
briefly?
please.
What is the goal that Rhode Island is headed toward with a 1% per year?
It's a great question, and this next slide partly addresses it.
Okay.
As you can see, this vertical dotted line here on the left is when the affordability standards began. And I'm happy to talk about our first evaluation of this policy, perhaps as a precursor or reference point for what Vermont is considering. But essentially, when we look at what primary care spending looked like before this policy versus after, basically this blue line shows you that total aggregate primary care spending in terms of millions of dollars in the state increased. It certainly increased. There's no doubt about that. And this increase was driven specifically by non-fee-for-service primary care spending. That is, support or investments in primary care delivered in a lump sum fashion, analogous to the per member per month or per patient per month subsidies that Medicare has tried to do. And there has been a lot of discussion, and I'm happy to go through this more, of the conceptual basis underpinning why non-fee-for-service efforts to support primary care might make more sense than fee-for-service new fees. But those remain 2 potential avenues for helping primary care. At the end of the day, one might argue that the amount of help is what matters rather than the mechanism of the help. But the mechanism of the help also gives you some different financial incentives. Here in Rhode Island, in this example, we see that non-fee-for-service primary care spending rose from somewhere around $3 million before the policy to somewhere around $52 million by 2023. And that is a large increase, which leaves this middle gap, the fee-for-service portion. So as you can see, the fee-for-service portion on primary care spending has not really changed all that much, but the increase was really driven by this prospective payment or per person per month type of support.
So in Rhode Island, does that include a community, a health team approach, or is it strictly for the primary care provider?
Great question. So the support for primary care was tied, at least initially, to patient-centered medical home certification. We've also seen that much of these non-fee-for-service investment dollars went to physician organizations, so accountable care organizations or provider groups that were taking on responsibility for a community or an attributed population of patients. The accountable care organization concept has deep roots here in New England, in the Northeast, in large part thanks to our colleagues at Dartmouth. And this is an approach that Rhode Island has also built on. And so it remains a question of intense interest from us in the research community, how the dollars flow from payers down to the front lines of primary care practices. That funds flow remains less well understood. But what is better understood is that after the state made this deliberate effort to support primary care in the face of the common challenges we all face. It was able to deliver more dollars to primary care. And we are currently studying the impact of that on total healthcare spending and on quality of care. Let me just finish up here by touching on what the private sector is doing in response to the primary care crisis as well. And this is important because when the federal approach and the state approach, let's say, when they are not yet adequate to meet perhaps what patients and frontline clinicians want or need, then often the private sector will step in on its own to provide people relief and solutions. And we're seeing this in the form of the rise of free market models of primary care practice. As many of you have undoubtedly heard, primary care physicians are increasingly leaving traditional models of practice for concierge primary care practices. What does this offer them? It gives them much smaller patient panels, more time with patients, more face time, which is very much valued. It reduces their burnout, their administrative responsibilities. It many times allows them to lengthen their clinical careers rather than retiring early. They might practice for several more years with a smaller panel. What does this offer patients? Well, for those who can afford it and have the means to enter this market, patients receive much quicker access, same day appointments, next day appointments. They can call their patients on the phone. Their physicians will often come to the house to do home visits. They may even accompany the patient to their specialist visits. This is obviously not the vast majority of the primary care system in this country, but it's important to note that it is certainly a growing trend. And especially here in the Northeast, we see a lot of this. This has essentially made primary care go from more of a common good, which many of us in society believes it sort of intrinsically is, although people have varying opinions of that, to a free market commodity, at least more of a free market commodity. And that has a lot of implications for what it means to be a primary care clinician and be a patient with primary care in our communities or in this country. Certainly, there are benefits to both the physicians and the patients, but because this hinges on the practice panel size being much, much smaller, it means that only a portion of society is able to access this type of primary care. And for every primary care physician, at least in the short run, who leaves for this type of practice model, there are many more patients on that physician's panel who are necessarily left looking for a new primary care doctor, just at a time when there are no new primary care doctors or capacity to take on those patients. So in the short run, this actually exacerbates our societal primary care shortages, even as it solves the primary care crisis for a small portion of society. And this is not just happening in primary care, as you can see in this graph on the right. This is happening in many, many specialties, many internal medicine subspecialties, in imaging, even in procedural specialties, and certainly in behavioral health for decades. So this is increasingly a trend that is just happening alongside what the federal response and the state response are trying to do. And you can either interpret this as sort of a test or judgment of how well our public response is doing, because if the public responses were handling the primary care needs well, then perhaps the private sector would have less of a need to step in. Or you can simply think of this as the private sector seeing opportunities where there is a market and creating a market where there is demand, regardless of what the public sector does. In either case, the federal level, the state level, and the private sector are all responding to the primary care crisis in different ways. And I know today we're talking about the state level here, but I just wanted to put this in the context of what's going on more broadly. So let me stop there. I'm happy to answer any questions or talk about any of these studies or areas of research in more detail. Thank you for your time.
No, thank you very much. This is very helpful. And I know we struggle with the the whole direction with direct and concierge practices right now, because it does pull away from what I call the risk pool or the patient pool for across the community, the common good, it said.
Agreed.
So with all of the work that you've done and the research that you have before you, understanding code expansion and the rest, we're in a place right now where we're looking at how do we fund the increase and getting to a higher percentage of primary care. And so within our bill, thinking about the code expansion is one thing. You've indicated that. It will be a balance, of course, across the regulatory world. And what other options are there for increased funding for primary care based on your thinking, your research?
Well, thank you for the question. The main paths for investments in primary care are doing it on the fee schedule through either augmenting the value or the prices of existing codes or adding new codes into the fee schedule, or doing it off the fee schedule through a per person per month or per person per year lump sum kind of basis. There are trade-offs to both of these options. On the first one, the fee schedule options, often states do not have as readily available of levers as the federal government for that, because almost all payers in this country use the Medicare physician fee schedule as the backbone for negotiating payment contracts, for the relative pricing of services. So for example, the fact that a 15-minute cataract extraction is valued at 10 times a 15-minute office visit, which is the backbone of primary care, is a relative pricing that is originating from the Medicare fee schedule. And it basically spreads across the healthcare system because private plans and Medicaid often use basically the same RVU or relative value unit or pricing relativity of services in the fee schedule. That same relativity basically means that if you want to support primary care, you might have to start with the Medicare fee schedule. With that said, however, the concept of an accountable care organization or a physician organization or provider group being paid in a prospective manner, managing risk, having that budget ahead of time, the conceptual basis for that does include the ability to determine your own fee schedule. You've already got the budget at the beginning of the year. You already have the lump sum amount you're using to manage your attributed patient population. You do not, in theory, need to abide by or live by the existing fee schedule with all of its relative price distortions between procedural services and non-procedural services. It is easier to live by and just rely on that. It's certainly easier to simply use what's always been there. But in theory, one of the advantages of an accountable care organization is that you can decide that if you believe primary care is worth more, at least relatively speaking, a little more than other services, you can price it a little higher on your fee schedule. There are some legal aspects of this that are a little trickier, but conceptually, that lever is available. We simply have seen that very few, to basically no accountable care organizations across the country, at least that we know of in the academic literature, have really taken on that task of redoing the fee schedule to value what they value. Many would say they value primary care, mental and behavioral health care, maternity care, just as a few examples. But few have really taken on what is admittedly the hard work of redoing the fee schedule. But you can do that. So that's the fee schedule path. And a state could also give a provider organization the budget, allowing them to then shift around the relative pricing in their fee schedules to invest in primary care. Again, it's an uncharted path empirically, but conceptually, it's available. Many provider organizations would know this from the inside that primary care improves health. I mean, the evidence on that is abundantly clear. Primary care improves health. It's even associated with longevity and lower mortality. Areas of the country that have more primary care physicians available happen to also be areas of the country with lower mortality rates. Whether that's strictly causal can be debated, but the association is quite strong. And the value of primary care for patient well-being, for having the longitudinal relationship, walking through the stages of life with a trusted doctor, that we can all relate to and has really been shown for many, many years in the literature. So physician organizations arguably know the value from the inside and would have the motivation to do some work on the fee schedule if you take the fee schedule path. If you don't take the fee schedule path, you actually can find some further advantages. What do I mean by that? Well, many states only have jurisdiction over certain parts of the payer population. As you know, states have authority over their own Medicaid programs and only over their self-insured state employee covered lives and over the fully insured rather than self-insured commercial lives. Nationwide, about 60% of the population with commercial insurance, most of whom have it through an employer, have it through a self-funded plan or a self-insured employer. States do not have the authority to tell a self-insured employer what to do. Only the Federal Department of Labor has that authority. So states are limited in dictating what can be done given a patient's insurance mix or insurance status. So states can really only touch Medicaid, state employees, and the fully insured commercial lives. But if you move to the second option of supporting primary care off the fee schedule, now that opens up that span of possibilities. By giving practices a lump sum amount prospectively, the same way you would pay an ACO contract conceptually, you can now do that and support lives in the practice no matter what type of insurance that life has. You can support a practice based on the number of patients it has, based on perhaps the social determinants of health faced by those communities, by that patient population. You can subsidize more disadvantaged populations directly through the prospective payment, the per person per month payment that's off the fee schedule. And you can really count one life as a life regardless of the insurance status. There is some simplicity and appeal of that, that your subsidies, your investment need not only go to the lives under your jurisdiction, but you can help the residents of your state directly for primary care regardless of what type of insurance they have. And that allows you to get around the ERISA or self-insurance issue. And that also allows you to dictate where you think the support should go more or go less. You might think that not all practices need the same types of subsidies, the same level of subsidies. And you might think that practices associated with hospitals or in certain areas or in certain systems or whatever it may be locally might need a little bit more or a little bit less of the investment. And you can titrate that from a policy perspective much more easily in option 2, off the fee schedule. So there are some of these trade-offs, and I don't think that by studying states thus far, we in the research community have learned all of the lessons yet. We certainly haven't figured out everything, and there's a lot left to learn. But I think the initial states that have undertaken this journey have taught us a lot. And I think all the federal efforts over several decades and the private sector responses have also added a lot of important insights to this area of work.
Thank you. This is, it's good. I mean, it resonates with some of the thinking that we have going on and trying to sort out where we land is we're in the process of guiding ourselves to the target and center field. So, any questions, committee, for Dr. Song? This is a start for us. Jen, I'm gonna turn to you. Do you have a question that you'd like to ask? So I think we're good. But we may come back to you. And I know that you've been in touch with, Elliot Fisher at Dartmouth. And I've been talking, others have been talking with him as well. So we'll try and put this all together so we can build a Vermont model. We have looked a little, as we were talking about global budgeting for hospitals and we're moving in that direction. It's almost like global budgeting for primary care. So at the other end of the spectrum, and then trying to sort out who gets what, how. So.
Yeah, agreed.
Yeah, okay. So we're good, I think. Thank you very much. I appreciate your
Thank
time, your patience with us this morning. And we'll get back to you as time goes on, I'm pretty sure.
Sounds great. Thank you so much for your time. It's an honor to be here. Thank you for all of your work and service of the
All right,
public.
thank you.
Take care.
Terrific. All right. We do have S-189 coming up, which is scheduled at 10 o'clock. And now it's 10:15, so we're right on schedule. So we're gonna move right along to 189, and we've got I don't know where to begin with this one.
I have language. that
Why don't we
was
begin with that?
Post whenever you are ready for that.
Yeah, why don't we do that? Thank you.
Yep.
Thank you for the reminder. I had you last, but let's do that first, and then people can look at the language that's there. We can have
Does that make sense?
Yes, that totally. Yeah, Madam Chair, for what it's worth.
Yeah.
So, Diane Lanford, Green Mountain Care Board. I just wanted to say, because, Emily, who was, scheduled to join Jill on this morning, is sick, very sick this morning, and Owen is on his way over.
Okay, good.
Now,
That's good.
just wanted to.
At least we got a replacement. So. Okay, good.
Feel better, Emily.
So you're just posting that now, right?
Yeah, she is posting it now and I'm just pulling it up from Word up so we don't. All right, good morning, Jen Carvey from the Office of Legislative Counsel. So I have here a strike all amendment to S-189 that shows the proposed changes from the bill as introduced using markup. And so sort of from an overall perspective, the main change that this draft would make is to still require notice and a public engagement process, but not create a specific approval mechanism for proposed hospital service reductions or eliminations. So this is S-189. It's an act relating to an approval process for reducing or eliminating hospital services, although you'll see at the end that I proposed changing the name, the title of the bill as well. So this would amend the new section that is being added on hospital service reductions to, instead of saying approval required, saying notice required. And it strikes the specific language in the beginning saying hospital shall not reduce or eliminate any service without approval from the Secretary of Human Services. And then just carrying that any service concept into the new language saying hospital that proposes to reduce or eliminate any service shall. And then, as I said, it keeps this whole notice of providing notice of intent to the Agency of Human Services, Green Mountain Care Board, Office of the Healthcare Advocate, the legislators who represent the hospital service area, explaining the rationale, describing how it is consistent with the statewide healthcare delivery plan and the hospital's most recent community health needs assessment. It keeps the requirement to post the notice of intent on the hospital's website and publish it in a newspaper of general circulation, conduct a public engagement process, including at least one public hearing, and to provide a summary of the community's response to the proposal, including the public comments received to the Agency of Human Services. Takes out the weekly requirement, but just says following the conclusion of the public engagement process. So they would kind of compile all of the public comments received and provide them to the agency. Then it strikes the language requiring the Agency of Human Services to review the proposed reduction or elimination, and the criteria for approving it. And instead simply says, so we've had the hospital provide the notice, we've had them do the public engagement process. And now if under the revised proposal, if a hospital elects to proceed with reducing or eliminating a service after completing that notice and public engagement process, then the hospital must notify the Green Mountain Care Board within 5 business days following its decision to reduce or eliminate the service, so the board can review the impact on the hospital's budget. And then keeps language in the hospital budget review section, keeps the striking of the process added last year, and just revises the language for consistency with that new approach, which would say upon receipt of notification from a hospital pursuant to 9405 DB that the hospital intends to reduce or eliminate a service following its completion of that notice and in public engagement process. 9405A, the board reviews the impact of the reduction or elimination on the hospital's budget and still allows the board to adjust a hospital's budget if necessary to reflect that elimination or reduction. And keeping language saying that may include directing that any savings related to the reduction or elimination are returned to payers and Vermonters to address affordability concerns or are reinvested in primary care prevention and other community-based services. The act would still take effect on passage, but the title would be amended to say an act relating to establishing a process for reducing or eliminating hospital services without an approval process.
So it shortens the process significantly, puts in the public engagement process.
Right, so it doesn't change any of the timing of the process except taking out the Agency of Human Services approval component.
Okay, but there's nothing here that has the agency evaluate the recommendation for service reduction or addition. In the
We don't address addition. There's no addition does not have a process. I mean, it may through the Green Mountain Care Board and their budget review, but no, it strikes the language that has the agency review the proposal and consider the community's response and the impact of the proposal on access. And then takes out language saying that the agency can approve the proposal if the agency finds it not inconsistent with the strategic plan or community health needs assessment, that it doesn't unduly burden access and the advantages outweigh any disadvantages.
And the notice that is sent out goes to the legislators in the area, the hospital area, and doesn't go to HROC or any other place like that.
Right, it goes to the Agency of Human Services, the Green Mountain Care Board. This is the same as in the bill that's introduced. Office of the Healthcare Advocate and members of the General Assembly representing the hospital service area.
Okay.
We can certainly add anybody else on this.
I just
Not
thinking
making changes to that.
when I was thinking about when the Brooklyn decision hit the fan, I was asked. We need to put maybe HROC in there for the people who are keeping an eye on performance.
Yeah, and you can have the committee's jurisdiction during the session or HROC outside of the session.
Yeah, something like that. Okay, all right, so those are some of the areas that we're going to hear about for. Okay,
All right.
thank you. And we're gonna listen to, why don't we, this was a board request, the bill, S-189. Owen, do you want to kick us off with this one?
Morning.
Good morning. Welcome.
Owen Foster, the chair of the Green Mountain Care Board. I called in to pinch hit a little last minute, so I apologize. Emily with she's ill today.
Okay.
In short, I disagree with the change striking AHS's review. The reason for that is where this bill currently sits is there would be no review or approval process at all. The hospitals make the decisions, and that's fine, except when the hospitals have made the decisions in the recent past, they haven't done so with a view towards the system. They've done so with a view towards their institution, which is not wrong. They have fiduciary duties to their institution, but it doesn't have the overview of how is this going to all fit and work together. I believe that review should be at the Agency of Human Services. This committee, the legislature, has tasked AHS transformation. AHS has received $194 million a year to drive transformation. AHS in S-126 last year was tasked with transformation in Act 51 in 2023. My concern with it at the board is that we get them the review pieces ad hoc. So we get one without any resources to consider how it fits with all of the other changes that are happening, and without any consideration of the agency's strategic plan and vision as to how they want to finish things. So if I get a review decision and I don't know what the agency's perspective is on how they're going to spend the rural health fund or what their statewide strategic plan is going towards, I might make decisions that are not consistent with what they want to do. That does not make sense to me. When I was applying for the care board, one of the discussions I believe the center lines you asked me was policy versus regulation. And I think we've all kind of landed that the care board is regulation and policy sits with the agency. Redesigning the system, to me, is policy. It's a policy choice, what you put where. And when you have a statewide strategic plan, why would you have another entity make decisions thumbs up, thumbs down, and have somebody else design the plan? It doesn't make a whole lot of sense. I think if we go through the recent history of some of the changes that have happened, we can see how they're actually harmful to the system. So having no review may actually leave us with a number of things that we really want, right? And that is what happened. Let's start with UVM. UVM cut primary care, it cut dialysis, it cut inpatient psych. There's no one in this room that can tell me that that's what we wanted for the state system. So if you have no review, you will have that. That's not what we want. Second, cut burden. I don't believe anyone ultimately believes that cutting burden was the right decision for the state from a strategic standpoint. If we have no review, we will lose more burden centers. We will have maternity deaths. And then most recently, we had Rutland cut inpatient pediatrics. Again, that also looked like it very likely would have added cost to the system. It would have saved Rutland money, yes. But for the system, if you're trying to improve affordability, it very likely would have made it more expensive. I say that because the patient still would have gone to Rutland. They would have gone to the ED. There wouldn't have been inpatient pediatrics there. They would have been put in an ambulance if they could get an ambulance. They would have been moved to Burlington. They would have then been inpatient at Burlington or gone into the ED first. You're duplicating the services that are being provided. That adds cost to the system. It doesn't remove them. So if we're not reviewing from the system perspective, whether these are good or bad, I think we're actually going to make costs more expensive. So I just don't agree with having no review because I've lived this and I've seen the changes. And I can't point to one of these where I said, oh, that was the right thing for the system.
Okay, so let's suppose that this went forward without that system review that you're talking about, then what would be the consequences of that? What would happen after the public engagement process and then the decision comes to you possibly during the budget process?
Really good question. Incredibly complex.
Yeah.
Because it may, like, let's take the Rutland example or even the Copley burden example. So those birds at Copley, very likely are going to go to UPM or CPMC where they're double or maybe even triple the cost. So again, we've added cost to the system if that's actually approved or not even reviewed. So then it comes to the board, but now everything's out of whack because the insurer might need more money to cover for that additional expense. So that now they're paying $30,000 rather than $15,000. And also, if UVM is losing money on those birds, they may come to us and say, hey, we need more rate. We just took all Copley's birthing, right? So it really makes it very complex from a regulator and a budget standpoint to get a whole mess of these in the process. It may not even be beneficial to the state. I think theoretically, the way the statute's written is probably the best we can do without an approval process. And what the board could do is say, okay, Rutland, you cut inpatient pediatrics, that was 5 million in revenue, 5 million revenues gone. Or we could say you had higher prices to cover the losses. We're going to lower your prices because now you don't have those losses. But then you're shifting it somewhere else and maybe adding on 2 or 3 more touch points or higher prices. So it throws all of it. It was very confusing. And keep in mind, when we're doing this, we are doing 14 budgets in 2.5 months. So you're adding significant complexity.
So an added question to that, then, with this process, does it change what you went through at the board, the board went through when these other changes were made? Does it change what you know and how you act?
Yes. So the way I think I can so the way the statute was originally written, the board did the review and said yes or no. Yeah. But again, that was complicated by like we didn't have that system view or the strategic planning of where we wanted to go as a system. So this would change it in that the board wouldn't be doing a review, the agency wouldn't be doing a review, and the hospitals would be making their own decisions.
So going back to my question, then it doesn't really change where we are. Except there is a public engagement process.
Which I very much support. I think it's
Yeah.
really good.
Okay. Questions?
I mean, I think that's very complex and, I understand the system piece, try to maintain the system, but in reality, hospitals are a business, and when they're losing money on a business, that's their general reason why they want to eliminate a certain service, even though we may say we really would like to maintain that service in that event. Somewhere then that cost gets shifted to other costs. And if we're trying to go to a different way of paying for hospital services, where does that get made up? Because we now established what the cost is that they can get for these other services. So you're pushing the hospital to working into the negative. So that's a concern I have in where this would go. Also, you have a situation where some of these hospitals may have one person providing that service, that key service. They don't control that individual. That individual could retire, could move on to another location. And so then they're faced with,
Senator, what I'm going to say is, do you have a question? Because where you're getting to is discussion on the bill.
well, I'm looking for from the Green Mountain Care Boards indicating they want to maintain this control over the system. And I'm asking how you're going to do that in reality, when in fact the hospitals don't really have total control over their staff.
Right. So I understand the question. So I think I understand the question.
Right there.
2 things. The Green Mountain Care Board does not want to maintain control over this. We believe it should be at the agency of human services. Because they're the ones thinking about the system, the resources to do it. So, and then your point about people can leave and quit and retire or whatever it might be. Yeah, that will happen and you will lose the service. In terms of like working and driving them into the negative, the point is that there are some things we need to maintain in communities. And that's why you have regionalization, you have centers of excellence. Not everyone can have, we all recognize that. Not everyone can have inpatient center. There's going to be decisions made. And that's my overall point here, is that we want a strategic thought as to what goes where and to prioritize what we must have in the communities. And when the care board does it, we're not doing that because we're not redesigning the system. So the decisions that are being made are not with that overview. And that's not good for the system. If you allow the hospitals to just cut what they need to cut, the lowest losers, then you're just going to have a very, very bad healthcare system. The whole point of the healthcare redesign that the state began in 2022 was to have an intentional system. If we were to look at this all today, is this what we want? And the answer is not at all. So now, how did we get here? It's really by happenstance, how things got built, but it wasn't intentional. So states put a lot of money into, let's make sure we do this intelligently. And that might mean that there are some services that lose money. It might mean that you have to pay for some things differently. But what we don't want to do is the exact same thing of how we got here, which is by happenstance, have what we got, right? That does not work for patients. We talk about access. We want maternity deaths so people can't have births. No, we don't. We need to make sure we're actually having the services that we have to have prioritized in the communities, or you're going to have a bad health system, and we already do.
One more question.
I don't want to split hairs, but I actually want to ask a question about something you said, because I think it's important to the discussion. Are hospitals businesses or are they nonprofits providing a public good? Because I think the distinction is really important.
Yeah, all Vermont's hospitals are nonprofits. I think the points are kind of similar, actually. I mean, they have to be solvent. Right? And part of that might mean, like the way I look at it is you're losing money on birthing, but you're making, 10x margin on MRIs. Maybe you need to lower your MRI prices and move the prices over to further. Maybe you need to negotiate with the insurance companies so that you're actually keeping the services that we really, really need. It shouldn't be run just like a business. It should be run in terms of what the community needs, but there is also the reality that they need to be solved. And they're really pressured, a lot of them, especially in the rural communities.
That's my concern.
It's a good concern.
This, it's all concerning. Thank you for your testimony. I understand what you're saying. So this is going to be a discussion, I think, going forward. Mike Fisher. Welcome.
Thank you.
You haven't been here much.
I've been here a little while.
Where I've been, you need to be brought back to the real world.
The real world. Send it health month is the real world.
Yeah. No, you.
Yeah. Thank you, Mike Fisher, healthcare advocate. And I do not have something in writing for you because I am literally listening and reflecting on the conversation that's happening at the table. And so I do have a few thoughts. One of them is we find ourselves at an interesting moment right now. This sort of broad recognition that the task of right pricing our systems such that we can afford it is going to hurt, and it's going to be a tough transition. You have, built out a runway to move towards a different way of paying hospitals, reference-based pricing, global budgets, and we're not there yet. And the financial pressure is being applied today. The Green Mountain Care Board's draft hospital budget guidance has the -1% growth rate. So the pressure on hospitals is by last year, it's going to be applied this year. On top of that, we have this history of hospitals. I think there's evidence that hospitals have been interested in their aggregate bottom line and have at times put their revenue baskets in certain things like, sort of generally things like orthopedics and not things like family medicine or delivering babies or inpatients. And so when we apply pressure financially, in order to be able to afford the care that Vermonters need, the right business decision for a hospital in the short term might be to not deliver this, because they make a lot more money doing other things. And so I appreciate the addition of a public process. I think it's a step forward for the hospitals to be required to do a public process, but I don't think it's enough. I think in this interim time, hopefully not fantasy, that when we get to a place of having reference-based pricing and global budgets, that this will be, so these dynamics will be captured by those processes. But at this moment and in the transition to it, I think we're exposed in a different way and have a great deal of fear. And so I do want to just reflect a little bit of irony at the moment. I've been sort of asked the question of what's it look like when you tell a hospital you don't want to do something, but you got to do it anyway? Can you really do that? Here we have a moment where you have the likes of me and I think the board saying this is important, it's got to be done, and you have parts of the state government saying I can't do it. I spent a lot of time around these processes. The board, I don't want the board to be punished for its own success here, but the public process, the typical public process that the board undertakes for a thing like this, makes a difference. There's a thousand details about the experience of the Rutland inpatient story that you would get witnesses coming and telling you different stories about, but from where I sit, there was a big community of providers in Rutland who didn't feel like they had an opportunity to speak until there was a public process in place for them to come. And man, did they speak. And it might be interesting to hear their perspective. Ultimately, at least for the moment, Rutland withdrew its proposal to close its patient pediatric. And from my perspective, that was good process. People got to come to the table and speak out loud. And that doesn't mean that I can draw the conclusion at the end of the day whether the outcome is right for Rutland system, but process is important. So just to say it again, I think it's a step forward to have a public process at the hospital level, and it is, I think, very important, particularly at this moment, to have a decision maker have to entertain based on some parameters that you might frame up. Whether it makes sense, not just for the hospital, but for the region and the people in that region.
Thank you. Good. Okay. So we have Jill Mazza Olson is here.
Hey, good morning. Nice to see you all. Jill Mazza Olson. I'm the AHS Medicaid and Health Systems Director. So I just want to take a little bit of a step back just to make sure we're all oriented to the current law versus what this would do. So under current law, it's actually the Green Mountain Care Board that has this oversight obligation to end this decision-making process. And that's what the original version, that's what S189, the original version sought to change. It would have moved that process over to AHS. So current law is that this oversight process belongs with the Green Mountain Care Board. And there is an exception clause for the agency of human services so that if a change is happening that's sort of pursuant to the transformation work that we're doing and planning with hospitals, it would be accepted in that process. So that's where we're starting from. And so I think the question, honestly, that you're still wrestling with, and you hoped that we would come to agreement with the Green Mountain Care Board, is if you want to have this sort of regulatory oversight, where does it live? Right now, it lives at the Green Mountain Care Board. Chair Foster is suggesting it moves to AHS. As I testified when we first started talking about this bill, we don't think we can regulate what we help create. And that's what you would be asking us to do. So we are working on transformation plans with hospitals in a consultative way with technical assistance and helping to provide some of the antitrust sort of protection by having conversations with one hospital about what they're thinking, having a separate conversation with another hospital about what we're thinking, and then potentially bringing things together in a way that doesn't violate some of these federal rules that make some of this collaboration harder. And so we are actively engaged and involved with the development of all of this work, the regionalization, the internal work to create new efficiencies, the clinical collaborations. So I don't see how we can then take a step back from that and be the regulator. We've never thought, and this is what I testified before, we've never thought that it made sense to have the essentially the innovation work and the regulation in one shop. And so it's in two now. And if you want to keep it somewhere, we would keep it where it is with the Green Mountain Care Board. They are a regulator over hospitals. AHS really isn't a hospital regulator. And also, they do have the authority over the hospital budget, and these do ultimately become a question of hospital budgets. Why I'm comfortable with this language, as introduced, or this amendment, because I do feel like, so I think there's like near agreement, except on the nitty-gritty of what do we do. So the concerns about hospitals making decisions that don't consider the whole system, I think there's broad agreement that that's a concern, and that's something that we're paying really close attention to. I think there's broad agreement that we want to preserve certain kinds of services that under current payment models are some of the things that hospitals look to first when they are financially struggling, because literally of how they're reimbursed. In my view, we have a fair amount of levers already and are developing more to, as long as we have the notice and the public process, so that we understand what's happening in communities before hospitals can just sort of announce a closure. I think we have a lot of levers, and we're building more. Reference-based pricing is going to be another lever. We have hospital, global Medicaid hospital global budgets. We're moving toward other kinds of global budgets. So we have all these other payment mechanisms and regulatory levers that I think will help us influence how these things go, without necessarily building this sort of regulatory structure. So I think we would be comfortable with the approach in this amendment. I hear that Chair Foster is not, but if you really want to keep a process in place, we would ask that you leave the language essentially as it is today.
So we're getting used to this in this one. But both your comments, I would say both, all three of the comments we've heard this morning are very compelling. And so I'm not sure we're at a final place yet. It will somehow in the development of the regionalization and the discussion that AHS is having with and among hospitals and decision making, there are decisions in there, but some of it will be left to hospitals. We understand hospitals are very much independent, autonomous organizations, and they're trying to work together. We get that. Ultimately, the healthcare delivery strategic plan is going to be something. There will be decisions made within that. Somehow, it needs to inform any decision that's made around budgets that happen at the board level. At the same time, I think it's really difficult. I'm hearing what you both say. It's always been a question of mine, policy versus regulation. Now we're caught between a rock and a hard place because everybody's doing everything. And so here we are. I guess what I would say is let's have a short conversation. And then from my perspective, we're not finished with this yet. I don't think we can say, yeah, it has to be this way, or it has to be this way, and this is the group making decision. And the rest of you are going to have to live with it. I'm not sure we're there yet. And I do respect the comments that you're making, and I do respect the comments that Chair Foster has made and Mike Fisher has made. So this is me, I don't know, everybody can disagree with me, but having the public engagement is important, absolutely critically important. Who's involved with that? What information is taken in there? Is it all local? Is it regional? Is it information that comes from AHS based on the strategic plan? What is it? So is it, well, we'll have the public comment on it, and then, maybe we'll make some changes and then we'll go forward. Sometimes I don't know how this all will sugar off, but here we are again with competing interests. I think the interests have common goals. There's no question about it. So I will end there for now. I'll look around the room for comments. And I know you're sitting there. There's if you wanna,
Should I just stay here or move?
I think move back.
Okay.
We can have a broader conversation with folks and, just for a few minutes, because we do have some time to do this. We're eating into Ledge Council's time, and I know she's really unhappy about that.
Upstairs 11. So.
You're here at 11, I know that. We're moving on to 190 in a few minutes, but I just, go ahead.
Devin Green, Vermont Association of Hospitals and Health Systems. We appreciate the public process piece and the notification piece. We think that's really important. Question my members have had from the outset is, what happens if you say no to our proposal? Is the state going to subsidize these services so that they can be available? Are you going to give us the specialists that left? Like, what happens next? That is where we are struggling in this process.
Understood. So from with that in mind, then the process that currently happens, whether it's kind of a negotiation between board and hospital and other interested parties, that's a process that you're not opposing?
We don't totally understand how it works,
Yeah, okay.
right?
The comments.
I would tend to agree with Ms. Green on that. Like, it is very difficult to the point if somebody retires and the board says no. Keep in mind, the board's 5 people.
Yeah.
And you get 3 different viewpoints, and it can put them in a difficult position because you have 3 people making an ad hoc decision in that moment. To Ms. Mazza Olson's point, I agree with a lot of what she said. The only thing that distinguishes, to me, we still have the regulatory side. We still have the budget side in this bill.
Yeah.
Right. So but the policy decision is as to what goes where. And as AHS is developing the strategic plan, and as they're working with hospitals today, there are decisions being made. So I don't understand the distinction about why there can't be a decision. You're making decisions every day on what it looks like. Why aren't there decisions in this process?
Is it a decision or is it a recommendation? So I'm just caught between the here sometimes.
Well, it could be, I think you could come to a middle ground of a recommendation or an opinion on it, right? Because where we're struggling with is is this good or bad from the system perspective? That's what we don't know.
Yeah.
So if it's a recommendation from AHS, I think that's like, we believe, so to be fair to AHS, I think also this is developing as they go. So they're getting these today, or they would be getting these today or tomorrow, but the strategic plan isn't done.
Yeah.
So is it really fair to say, hey, thumbs up, thumbs down? It could be a recommendation. It's the same thing with the board. If we don't even have a vision as to what the strategic plan is, how do we thumbs up?
Yeah. So I mean, right now it's the hospital that's saying we fit in with the plan. But maybe there's some other suggestion on the part of AHS that, yeah, that it does or does not. This really fits in with the plan. It really doesn't. And these are the concerns. These are the budgetary concerns I know hospitals will have. But go ahead. I'm Joe. Go ahead.
Thanks so much, Joe Olson. So I one of the things that I worry a little bit about is that there's an idea that we're going to create a static strategic plan that it just sort of lays out exactly what is going where, rather than actually what's really happening, which is we are living in a dynamic process where there are changes constantly happening. And so I don't think there's ever going to be sort of just like a laundry list that we can go up against and say yes, no, based on the laundry list. So I'm a little worried that people think that we're creating something that
I don't think any of us at this table are thinking that.
Great.
It's always been an action plan.
Yes,
It's always been an action plan.
exactly.
And so the changes are coming. So we've seen that.
Yeah,
I mean, the list that Chair Foster gave us with dialysis, birthing, pediatrics, that's a dynamic process. So the concern is, does that decision fit with the ongoing regionalization decisions or actions that are being taken? So for me, it's not, is it the decision that goes, you decide you can do this or you can't do that? Or is it a recommendation that it is fitting in with the negotiations that are going on? And there's a public hearing that's going to help inform that. So, trying to figure this out.
Devin Green, I think a public hearing provides a lot of accountability to that hospital. And we are willing to do that piece. And what I would ask going forward is if these decisions fit into the plan, that the Green Mountain Care Board and AHS come to those public hearings and support those decisions and stand behind them. But if
I'm not sure the
AHS and the
board
Green Mountain
could
Care
do that,
Board
but as a planning piece, the AHS might, I don't.
or legislators, we've just asked for state support on some of
Making me
these
drive
decisions.
to Bennington.
We're gonna make you drive to North Country. But we, like, one way to get, like, we understand we need to be accountable to our communities. We think it would be very powerful if the state stood behind some of these decisions, that these very difficult
Understood.
decisions that we're gonna have to make. And if the state doesn't stand behind them, their absence will be noted. And a lot of times there are consequences that come from those decisions.
Okay, here we are. It's good. Okay, so my suggestion. So this committee really enjoys the hallway conversation. And if there's a way that folks could get together and make suggestions, you've heard our comments. I mean, I'm thinking your comment about having AHS or board put information in during the public hearing process, that's one. AHS or board making a recommendation, that's a number two, and who does that? But I think given the work AHS is doing on regionalization and on the plan, a comment would be helpful, or a recommendation would be helpful. I'm not convinced that it's a cut and dry decision. I don't know if we're there yet. I mean, we're gonna have to come back to this. I know we're gonna have to come back to this, regardless of what we do. We're gonna have to. Anyway, so let's hold that thought, and we'll continue the conversation. It is important that this bill have a path forward this year, and I really respect the recommendation that the board has brought within the original bill. And it does begin to look at how we separate regulation from policy making. We have to keep doing that in some way. And I do respect the AHS in this, because this is not where they work in the land. Okay. Where did Jen go? Yeah, Joe, I'm gonna say, let's take a 6